It's Dr. Joy here, and you are watching Delivering Joy MD. Welcome to Well Woman Wednesday, where today we're talking about something that you probably don't hear a lot about, and that is substance use disorder during pregnancy. September is Fetal Alcohol Spectrum Disorders Awareness Month, and that is something that occurs when moms use alcohol. Alcohol may be used along with other substances in pregnancy as well. So today we have an expert who is going to talk to us about this. Dr. Tricia Wright, who is an OBGYN and a board-certified addiction medicine specialist, is here to talk to us about substance use during pregnancy and particularly alcohol use. Make sure you keep watching. All right. I have a wonderful guest today by the name of Dr. Tricia Wright. She is a physician that practices at the University of California, San Francisco. And she has a special interest in how we think about substance use disorders in pregnancy. She's an OBGYN, go girl gang, and she's going to be talking to us a little bit about what she does and how she helps families and parents to recognize and deal with substance use disorders. And particularly today, we want to focus in on what happens when we use alcohol during pregnancy. So please help me welcome Dr. Tricia Wright. Okay, so nice to have you, Dr. Wright. Thank you for joining us today.
Thank you, Dr. Joy. That's wonderful. I'm glad to be here.
So, I was talking a little bit about alcohol use disorders with some colleagues, and we were kind of asking questions about screening, like what's the best way to screen patients to see what substances they're using, during the time of pregnancy or throughout pregnancy. And I was really shocked at how many OBGYNs kind of were not in the know about substance use disorders and alcohol use disorders in pregnancy. Do you find that a lot when you educate other physicians?
Oh, yeah. It's amazing how many times I'll find, just talking to my colleagues and other physicians that, about one of the most common complications we see or don't see in pregnancy because we don't ask the right questions and we don't have the right relationship with our patients. There's so much stigma and discrimination that it's really hard to get the right information to be able to treat patients as we would with any other medical disorder in pregnancy if we think about substance use disorder in that way. So the best way really is to as a physician is to have a conversation with your patients, to ask them, validated screening questions. There's a couple out there that are very helpful. One is, the 4 Ps. So, and before you got pregnant, did you use drugs or alcohol during this pregnancy? Have you used drugs or alcohol? Do your parents have a problem with drugs or alcohol? And does your partner? And the way to talk about that is, it tends to bring it as a non-stigmatizing way to talk about it. Sometimes people are more comfortable discussing, what their partner is doing, what their parents did, than that they themselves. But it can be a good screen to build, kind of rapport with your patients and kind of, ask them what's going on.
I think it's definitely about relationship and building rapport with patients so that they can then trust us to tell us these things that might be socially taboo, I guess, that people might bring judgment for. And so, in terms of substance use disorder in pregnancy, it seems that you've built quite a following and a practice doing this. So how common is substance use disorder during pregnancy?
So if we talk about just illicit substances, it's anywhere from 4 to 8%, depending on the population being studied. If we talk about alcohol use during pregnancy, it's much more common. And if we talk about cannabis use and tobacco, it's even more common than that. So it really does depend on the substance and the population. But it's much more common than a lot of things we do screen for. And so it is something that we should be talking about.
It's probably a lot more common than, say, toxoplasmosis, but we love to get that test, right?
Exactly.
zebras, but we don't necessarily have our eyes open for the horses, the things that are much more common in our area. And so, I'm on the other coast in Georgia, but I know you're out in California. Do you see differences when you were just talking about different populations? Do you see differences in the particular substance used based on where you are in the country?
Definitely. So I moved here 3 years ago from Hawaii, and in Hawaii, the illicit substance most used was methamphetamine. The illicit subject, it's still illicit in Hawaii, but it's not for medical purposes. But cannabis, extremely common in Hawaii. Probably even more common here in California because it's completely legalized, and we don't even screen for it to some extent. And, people ask me, what are the effects of cannabis in pregnancy? And we have some data. Unfortunately, the data we have is fairly old with different concentrations before it got even stronger. And so really teasing out that data is hard. And then I know on the East Coast, there's a lot more opioids, and there's so much focus on opioid use disorders and prevention of neonatal withdrawal or neonatal abstinence syndrome that because it has such an effect on the newborn, and it can be so expensive that there's all this focus on that, and then they lose focus on the really common misused substances, such as tobacco and alcohol.
Yes. And, certainly opioid use disorder in pregnancy is something that we should always pay attention to and treat. But there are also many other substances out there that are more commonly used during pregnancy. And one of them is alcohol. And so as we started working together with the American College of OBGYNs on the Fetal Alcohol Spectrum Disorder Project, I thought, wow, I have learned so much just about the effects of alcohol in pregnancy and why it's so important to screen and why it's so important to take a firm stance to say that there's no safe amount of alcohol that can be used during pregnancy and that there is no safe time during the pregnancy in which to use alcohol. And so, I was blown away by how many women receive sort of mixed messaging from us when we're talking about alcohol use. Like, oh, maybe it's okay to have a glass of wine with dinner or half a cocktail if you go out. As long as you're not in the first trimester, it should be okay. What do you think that mixed messaging comes from? Because we've known for a long time that alcohol is actually a teratogen, meaning that it can cause birth defects. Why do you think that still exists?
I think there's a lot of discomfort discussing alcohol use in our society, because it's so commonly used by so many people. And, there are, studies, people point to the Europeans and how common alcohol use is there. And I can point to a lot of studies that show that the rates of fetal alcohol spectrum disorders are so much higher in Europe. So we need to really emphasize to patients that they really, if they can stop using during pregnancy, they should. And if they can't, they really need to seek help. Because if they can't stop drinking in pregnancy, it may be a symptom of an alcohol use disorder that needs treatment, and it needs, compassionate treatment.
When you meet people who are having trouble with stopping their alcohol consumption during pregnancy, just, how do you counsel them? And what are some things that the average person can watch out for that kind of might let them know that they have an alcohol use disorder during pregnancy?
So, I try and use some motivational interviewing techniques. What do you like about alcohol? What don't you like about alcohol? and then kind of give them a menu of ways that they can deal with, if they're using alcohol to deal with stress. God knows we all did during the pandemic. And, pregnant women were no exception, because, dealing with having to homeschool their other children and the stress of working from home and everything else, as well as an overwhelming pandemic and all the fear with that, it's no wonder that they drank. But if they found that they were continuing to drink during pregnancy, really in a compassionate way, help them find other ways to deal with that stress, to deal with those emotions, and if that's not working, then to provide medications. So if you're finding that you're not able to stop, using alcohol during pregnancy, if you're using more than you intended, if you're having withdrawal symptoms or things like that, then those are all signs of having an alcohol use disorder, and you should be seeking specialized treatment.
One of the things that happens with dependence or physical dependence, which we are kind of replacing that addiction term more with physical dependence, is that you find that you can't do without it. Like, the quality of your life is not as good. You're not able to focus, or you feel ill or sick. You need, to take a drink several times a day, or you're having to take what we call eye openers, like actually just to wake up and get started, you need a drink. Those are all signs that you may have an alcohol use disorder. But the thing that I really think it's important to stress to people is that, there's no safe amount. So even if you don't have an alcohol use disorder, even if you could stop using alcohol during pregnancy, but just choose not to, then, there's still some risk that is associated with alcohol consumption during pregnancy. And I think we want to just kind of clearly make that point as many times as we can.
Exactly.
How did you get interested in substance use disorders and in working specifically with pregnant populations?
I trained at a program that had a great clinic that helped patients with substance use disorders in pregnancy. And one of the first developed in the 1980s, and then when I trained in the 90s, I that's kind of where I grew up seeing that model. And then I was in private practice for 6 years, and in Hawaii, we had a huge methamphetamine. They have a huge methamphetamine problem, and there was no such clinic there to help these women, and there were a lot of people getting their children and their infants taken away by Child Protective Services, and so really wanted to take care of these patients so that they wouldn't lose custody of their children, so they could get help, and so they could parent adequately. And we've had, the clinic's still open even after I left, and just continue to have really good outcomes for patients and their families.
Wow, that's amazing. What a compassionate heart you have, because many times I see medical professionals running from that population. Like, I've even seen some people actually dismiss patients from their practice because they have a substance use disorder. So I'm so glad that you were able to set that clinic up and to make a way to help folks. And I think that's one thing that we really have to be very careful about is judgment and stigma, because if you are judging someone, it's usually pretty hard to help them. So, how do you approach these conversations with patients when you suspect that there is a substance use disorder or an alcohol use disorder, and maybe they have not self-disclosed? Because that's something I always struggle with.
I start out talking to my patients, giving them other, in a non-stigmatizing approach. I ask all patients about things that affect their health, and I start out with, kind of less stigmatizing things. How much exercise do you get? How much sleep do you get per night? How much alcohol did you drink before pregnancy? How much alcohol are you drinking now? Trying to ask it in an open way, in, not stigmatizing. If they don't disclose their use, I said, that's great that you're not using alcohol now, that's great that you were able to quit, because we know that no amount is safe during pregnancy. If you have a problem, if you feel like you're having a problem, stopping alcohol at any point, please let me know, because I'm open to talking about it. And the good thing about prenatal care is it's so longitudinal, and we have multiple opportunities to build relationships. So I think it's an ideal time, and people are very motivated to change. I mean, the absolute overwhelming majority of pregnant people really want the best thing for their infant and their child and themselves. So using that knowledge and empowering patients.
Yes, and I think that is a great population to work with. One of the things that we're doing in our practice is working on opioid use disorders, since we are on the East Coast. And I have never seen a group more motivated, because these patients, these moms really want the best for themselves, for their pregnancies, for their infants, and they're very motivated to do something different. So I really love to see that motivation. One of the things that I'm learning a lot is that when a mom or a pregnant person is using alcohol, there tends to be like kind of a multiple substance thing going on here. Like maybe they're drinking alcohol and smoking marijuana, or drinking alcohol and taking pills. So for those folks who might find themselves dealing with a polysubstance use disorder, how do you approach those patients? That's very interesting to me, because it's like, okay, we have multiple things that we need to deal with, and maybe multiple things that we need to treat at the same time during the pregnancy. And so many times patients are really, really cautious about the medications and the therapies they want to use in pregnancy.
Yeah, the good thing about alcohol or opioid use disorder is that there are 3 approved FDA-approved medications to treat opioid use disorder, 2 of which are strongly recommended during pregnancy. Both methadone and buprenorphine are approved and recommended for treatment of opioid use disorder in pregnancy. And so, and your point is very well taken, because 45% of patients with an opioid use disorder also consume alcohol or have an alcohol use disorder. And so what I try and tease out as an addiction specialist, because I also am board certified in addiction medicine, is to tease out all of the different substances that they may be using, starting with the things that are really dangerous for them to withdraw from, such as alcohol, because alcohol withdrawal, if not treated appropriately, can lead to seizures and death even. So that is one of the dangerous things, and the things that, you don't want to stop on your own. And then the other thing to focus on is asking about benzodiazepines, because those are extremely common when you have both alcohol and opioid use, and also can be very dangerous to stop abruptly without weaning off. So, and then getting to marijuana or cannabis, as I prefer to call it, because marijuana can be a very racist term. Asking them about cannabis and their beliefs about cannabis and how they think it affects the pregnancy, and then giving them some brief advice about that, talking to them about cannabis hyperemesis syndrome, because some women use cannabis to treat nausea and vomiting during pregnancy. And so, talking to them about the different effects and the unknown fetal developmental effects and possible long-term effects of cannabis use. So, really focusing on the things that we can have medications to treat, but also, the other substances that they're using, and tobacco, treating tobacco, use disorder, giving them nicotine replacement and not ignoring that. can be helpful too. Because the reasons why they're using substances are fairly similar across the substances. Women use substances because of depression, because of anxiety, because of post-traumatic stress disorder. One thing I can say is that in our clinic population, about 70% of women had a history of either current or past domestic violence, and about almost half had a history of childhood abuse or neglect. So these patients are using the substance to deal with stress and anxiety and horrible things that have happened in their lives. They're not using it just because they, want to go out and have fun on the weekends.
Such a key point for everybody to understand, because if we are ever going to stop the stigma associated with substance use disorders during pregnancy, then we have to actually look at the underlying cause and the fact that many folks who are using substances, period, just across the board, whether they are pregnant or not, are doing so to self-medicate something else, to self-medicate major depressive disorder or generalized anxiety disorder or post-traumatic stress syndrome, which many people deal with, particularly women and women of childbearing age. A friend of mine always says that if you don't deal with your issues will deal with you. And I think substance use is one of the ways that our issues begin to deal with us.
Yeah. Exactly.
Yeah. You mentioned something that I thought was something that everybody should consider, and that was about sort of this whole idea of I'm just going to detox or go cold turkey. Can you talk a little bit more about that for a person who's pregnant and maybe using a substance?
Yeah, it definitely depends on the substance. There's a really we know about with opioid use disorder, detoxing or withdrawing or going cold turkey is generally not a good idea, because we know the relapse rates are so high. And, even if you're able to stop during pregnancy, the relapse afterwards is astronomical. It's about 95%. And with those relapse rates are really high rates of overdose death, especially now with fentanyl contaminating the opioid supply. So that is why we all recommend using an FDA-approved product such as methadone or buprenorphine. And buprenorphine is also known as Suboxone or Subutex. Those are the brand names of it. But using either methadone or buprenorphine during pregnancy really improves pregnancy outcomes, really improves the ability to obtain prenatal care, and it really improves infant outcomes also. So, we encourage pregnant people not to withdraw. And withdrawal, we know, is, with opioids, it's not traditionally thought to be life-threatening if you're just, withdrawing on your own, but it can be so miserable that, I've heard patients tell me that they wish they were dead when they're withdrawing off of opioids. Contrasting that with alcohol or benzodiazepines, you really, especially if you have a really high level of dependence and have been using a lot of alcohol, you definitely don't want to withdraw on your own, because that can be very dangerous. So that is something that should be done under with the help of an addiction provider.
One of the things that I found, and one of the reasons why I got so involved in buprenorphine prescribing and learning more about opioid use disorders in pregnancy is because in a place like where I practice, it's very rural. I think our nearest addiction specialist is maybe 50 miles away. So we have to have an option for folks to be able to access care. And so that, I think, is also super important. And so if you're watching on YouTube, there will be some links in the description box for you if you need to find an addiction medicine specialist close by. And you can also always talk to your physician, your OB/GYN or your primary care physician about, finding these services to make sure that if you do need help to stop using a substance or alcohol during pregnancy, that you have the support that you need. You don't want to just kind of go it alone because, as Dr. Tricia said, it can be a beast to deal with, and it can also be very dangerous to your health, and in some ways dangerous to your baby's health. So I think that's a big deal. One of the things, Dr. Tricia, I see a lot is that sometimes in the healthcare community, when parents report that they are dealing with a substance use disorder, or they're using alcohol or cannabis, we see the claws come out sometimes, and I think the point that you made about people, using these substances to self-medicate or just to feel normal was a very important one. And so there needs to be a lot less stigma so that people can feel confident when they, need to talk to their healthcare provider about that. But you see almost like a disdain when honestly, these are medical problems, right? These are medical problems. You would not show disdain for a patient who came in who had a urinary tract infection that was recurrent. You would work on it. So, we have to consider that. And one of the things that a lot of patients or people who are pregnant fear is that if I disclose this, that I need help, then I might, go to jail if I'm using a substance that's illegal, or I might have my child taken away from me, or people will think I'm a bad person or that I can't be a mom. How have you in the past gotten past some of those fears and worries and kind of help patients get to a point where they can parent better? They can be a better parent for their child.
Those are all excellent points, and those are all very valid reasons why patients don't elect to disclose their use. If they're afraid that they're going to go to get jail, because they have every state but one, I think, has had cases where pregnant women have been incarcerated for using drugs during pregnancy. And 19 states consider drug use during pregnancy as a form of child abuse. So and thus will remove the child from the home, even if no abuse or neglect is confirmed. And so those are valid points, and we need to really work on improving the system, because I know that when women and children and families are kept together, and women are able to disclose their use and work with as a medical condition, that the outcomes are so much better. They're so much better for the woman, because we know that women that lose custody are much more likely to have just worse outcomes as far as relapsing to their substance use disorder, and worse outcomes as far as overdose death. So keeping the families together, improving our capacity to treat this like any other medical condition. I often, as far as urinary tract, I compare it often to diabetes, because we wouldn't arrest someone for having diabetes in pregnancy, even if it was uncontrolled and she had a stillbirth. So we really need to treat this as any other medical condition and normalize its care.
I totally agree. I think that this is something that will take a lot of work to dismantle a lot of the judgment surrounding. One of the things that I am noticing on the East Coast is that there's a lot of concurrent opioid and benzodiazepine use, and we are seeing a lot of maternal morbidity, severe morbidity, and even deaths, particularly if moms stop for a while and then go back to using the substance of their choice. We see a lot of overdose deaths. In fact, accidental overdose is one of the most common causes of death around the time of pregnancy in Georgia. So it's a really sad thing to see, especially when we have made such great strides, and now there are opportunities for treatment to help people avoid that. So it's just a really sad thing. And so, one thing that always pushing for is that we need to normalize treating these disorders and normalize allowing people to be transparent about the struggles that they're facing, because everybody struggles with something. Mine is probably food. So,
Like to.
I like to eat. So, but we all have our different struggles. And so if you are a parent, a mom, a pregnant person who is living with a substance use disorder. I know today we focused a lot on alcohol, but there are many substances, and sometimes people are using many substances at the same time. Talk to a healthcare provider that you trust, because we can't help you if you won't tell us. But if you tell us, then we're able to help you find resources and to get where you need to go. So I hope that you learned something today. I definitely did. I thank Dr. Tricia so much for coming on. Again, she's an OBGYN and board certified addiction medicine specialist. So she has so much expertise. So if you have comments, questions, drop them down and we'll work to try to get you answers. But we hope that this was very informative. And Dr. Tricia, thank you so much for taking the time to do this.
Thank you, Dr. Joy. This was fun.